It's my honor to welcome Dr. Mridula Malhotra, ma'am. She'll be talking about the essentials and strategic foundation in eyelid reconstruction. Over to ma'am.
A very good morning to the audience and panelists, my dear friend Manu. So, I must thank Dr. Neelam for giving me opportunity to present in this wonderful conference. And in her lecture, she has already taught us so much about grafts, suturing, techniques. So my presentation is just basic foundation of oculoplasty, essentials and strategic foundations in reconstruction. It's basically the small things you should remember while you plan a reconstructive surgery. So basically lid is composed of two layers, the anterior lamina and the posterior lamina. I will not go into detailed anatomy of the structures, but just that anterior lamina, basically skin and orbicularis muscle, function is to support the lid position, and it is very important for the lid closure and protection of the globe. And posterior lamina, the tarsoconjunctival layer, and it has a mucosal lining which prevents any irritation to the ocular surface. This preservation of mucosal lining and function of lid is very important because basically what is lid doing? It is just acting as a wiper for the tears and also keeping the globe wet. If there is problem in the movement or the posterior surface is rough, then corneal problems will happen. So if we remember that we have to keep the posterior surface smooth and anterior surface functional, and lid should close completely, so that will prevent any dryness, irritation and corneal problems like exposure keratitis. So basically eyelid defects are mainly caused by commonly trauma, second to surgical excision of neoplasms, by birth congenital colobomas, necrosis or psychiatrical contraction of eyelid following severe infections, following radiotherapy, cryotherapy or thermal burns. They can be classified as full thickness or partial thickness, and we have to always see whether the lid margin, the lashes, they are involved or margin not involved. Whenever patient comes, you have to evaluate complete face as a unit, discuss the problem, possibilities and surgical plan. In preoperative evaluation, detailed medical history and examination has to be done, whether patient is hypertensive, diabetes, on blood thinners, any anxiety. Blood thinners have to be stopped 1 week before the surgery. Ophthalmic history examination, skin examination, and when you are dealing with suspicious lesions like malignant tumors, you should go for lymph node examination and metastatic workup also. In general ocular examination, you have to do basically complete eye checkup, including visual acuity, cornea, any exposure, Bell's phenomena, fundus, ocular motility. Coming on to eyelid defect, you have to see size, what percent of the eyelid is there, like 30%, 40%, you can classify like that. Whether anterior lamina, posterior lamina or both are involved, whether lashes or margins is involved, it's upper lid, lower lid, how much loose skin is there, laxity of the ligaments, and location, whether it's near the lacrimal apparatus or at the lateral canthus, in the medial canthal area. So this is very important to plan. This is a basic set of instruments. So if you see, we will need calipers, we will need blunt-tipped scissors, sharp-tipped scissors, BP handle, retractors, a very good forceps, and a very good, blunt and as well as sharp-tipped scissor. I think they are, and a needle holder. They are very important. If your forceps and needle holder is not good, it's a very simple thing, but you will falter. You will not be very comfortable. Sutures basically 60 silk, 40 silk, 70 silk, vicryl, 60 vicryl, proline. These are the main sutures which are required. Usually we do eyelid reconstruction which are small, up to like small rotation flaps, direct closure under local anesthesia if the patient is cooperative. For children or for uncooperative patients or for very large defects, you need general anesthesia. For anterior lamellar reconstruction, basically you can reconstruct the skin by advancing the skin from the adjacent area, advancement flaps, or rotating a skin muscle layer from adjacent area, rotation myocutaneous flaps. Or if only anterior lamella has to be reconstructed, then you can take full thickness skin graft like from posterior auricular area or the other eyelid. Posterior lamellar reconstruction, you can do tarsal transposition, rotation flaps. You can take free autogenous tarsal grafts from the other eyelid, contralateral other eyelid. You can slide the tarsoconjunctiva. You can use tarsal substitutes like auricular cartilage, as madam has showed nice video in the earlier presentation. Also, you can use composite grafts like nasal septal contromucosa, hard palate mucosa. Also, abroad commercially available xenografts are there. Collagen implants are also there. Allografts such as preserved sclera, alloderm, they are also available. Now, surgical considerations, wherever possible, prefer autografts because there is a rare possibility of disease transmission with non-autogenous grafts or they may not take. Secondly, flaps or grafts with inherent blood supply. During bilamellar configuration, at least one of the two layers must have its own blood supply. And in the earlier presentation, we have seen the sandwich technique where we have taken a bilamellar graft, but we have sandwiched the orbicularis muscle in between them because we need original blood supply. Both the layers alone will not survive. I will not go into details of techniques of reconstruction, but basically we should all know direct closure for small lid defects and all direct closure with or without cantholysis, semicircular rotation, tensile flap, Hughes flaps, upper lid mid direct closure, periorbital and non-marginal reconstruction, full thickness skin grafts, glabellar flaps, rhombic flaps. Other speakers will elaborate on these techniques. Simple things like tissue mobilization, making the, undermining of skin, releasing the canthi so that we can further pull the lid and do the suturing tension free. So canthotomy and cantholysis is basic in lid reconstruction. So for canthotomy, you just take artery forceps, go to the lateral canthus, press it, and then give it a nick. And for cantholysis, if you can see this figure, from the surgeon's side, palpate the lateral ligament, and then for this, your scissor or the instrument should be, held perpendicular to the lower lid. You can palpate and then you cut. Releasing this will release lot of tension from your suturing. The suturing has to be tension free, otherwise wounds will gape. Another important aspect in simple lid reconstruction is vertical mattress suture. We should all know how to give it. It is a near, far, far near kind of suture. We can go through, we should use 6-0 vicryl, go through the meibomian orifice, say at 1.5 mm, then come out near to the other cut end, and then again take another meibomian orifice, 3 mm from the cut end, and then come far again. Keep it loose and long, because we'll tie it in the end. Then you suture the posterior lamina with the spatulate needle, with the absorbable vicryl sutures. 6-0 vicryl sutures are good, and you do not need to suture conjunctiva here. Just suture the tarsus, and it should be a partial thickness, otherwise the sutures will rub towards the corneal surface and cause problem. And this is followed by orbicularis suturing. Then you have to tie your vertical mattress so that there is pouting. Remember, this pouting has to be there, otherwise This, when it heals, it forms crater. When there is spouting, it forms a very smooth contour of the lid margin. And also you should give, for good results, the marginal sutures. One anterior and one posterior. Posterior where the conjunctiva starts, and anterior just behind the lashes. So this is one of my cases. Before surgery, looks like, superficial, but it was a full thickness cut with canaliculus. This is after 2 weeks and suture removal. I have left the vertical mattress sutures here. Usually I keep 2 to 3 weeks, otherwise it will not give good results. So basically, vertical mattress sutures with pouting of lid margin is very important, and when you have finished with your skin closure, look for any tags, any dog ears, and you should tackle them by removing triangular piece of skin and suturing thereafter. For malignant lesions, you should be ready with frozen section, or if you are well versed with Mohs micrographic surgery, but they all need pathologist standby and the facility. This is just a skin graft from posterior area. This is again one case. This case has failed 5 times earlier, 4 times elsewhere, 5th time I operated. But because this is very important to learn from this case, he looks okay. When this is on table in between, I'll show you the pre-op and post-op. Again, just see. So he came to me like this, and we did tarsorrhaphy, medial and lateral. But because there was tension in the sutures, it gaped open again. So this was after 5th surgery. And if you see again, so this is on table, he looks nice. But then I have given a graft here so that there is no tension. And this is after 3 months. Complications of eyelid reconstruction can be like any other eyelid surgery. There can be infection, swelling, wound dehiscence, hematoma, necrosis, dry eye, keratitis, exposure keratitis, difficulty in opening or closing eyes. We should always tell about need for resurgery, scar formation. Post-operative care, you have to give oral antibiotics, analgesics. Wound cleaning is very important part of the post-operative care. If he's admitted, you can always, clean yourself. Otherwise, you have to teach them betadine and saline cleaning, and also donor site care. Last but not least, good nutrition. If the patient is not having good nutrition, no protein, no vitamins in his diet, again the wound might not heal. Suture removal, skin sutures are usually removed the 7th day. Remove alternate sutures first. Prior to removing sutures, clean the sutures very well. Usually patients come with matting and all, but you have to clean and then do alternate first, see if the wound has healed. If it has not healed, you can again follow up 3-4 days and then remove rest of the sutures. Vertical mattress sutures should be kept at least 2 weeks minimum. Proper judgment of lid defects and selection of technique. Suture line should have no tension, a well-experienced surgeon, and individual's health, nutrition status. They are very important factors affecting the results. Thank you for your kind attention.